Well, thank you. It's a pleasure to be here. Yasu, as we people in Michigan don't say. It's a pleasure to be with you. I don't have slides for you because I only have a few minutes and I don't want to take up the time of the next speaker. So I promise you I won't take up all your time. Um, I won't give you death by slides, as we often say in these talks. However, if you want death by slides, I will be giving a talk to Dr. Artemis's group, some of her group, November 4 at about the same time. And it's a 2-hour discussion of the same topic. So if you really need, for your pleasure, death by slides, that's the one to tune into, because I'll have slide after slide after slide after slide, attempting to put you to sleep while I try to make a few points. This morning, and for you in the afternoon, I have a few basic comments to make and then see if any questions can be slipped in. Sorry I'm not there in person. I was there 2 years ago. Here is my certification from and my name tag and so forth from 2 years ago. I'd love to go to the yacht club with you and have dinner and continue these discussions. I wish we could take the plane and go off to Santorini. We'll look at the Bronze Age art there, or let's go to Corfu, or we'll go to Rhodes or Milos, see the volcanic islands. Lots of good things to do there, but I'm here in Michigan. We have 11 of our 13 grandchildren, my wife and I have privilege to see, and one of them is skating this weekend, actually in California. Another one is in a concert and all kinds of fun things. So we're very busy as grandparents looking at our kids and grandkids now. But this topic, although it sounds a bit sad, actually there's some good things we can actually say about it. There are two main points I'd like to leave you with in my brief discussion. One is, I do have an article that I'd like you to look at to get some more information about this topic, and you can read it. It's an in-depth discussion called Pediatric Suicide Review of a Pediatric Tragedy. It's in a journal called Disease a Month, which Elsevier, the big medical publisher, puts out. Came out last month. You can look it up in your library and take a look at it. Now, if you read it, I won't make any money. We have a very famous Donald in the United States, very famous, world famous, who sells Bibles and watches and things and makes money, according to the news media, about that. This won't give me any euros if you read this, but it will give you some information. I put together an international team of individuals to look at this topic. Why do children and teenagers, young adults kill themselves at such high rates in the United States and around the world? Why do they do that? What are the causes? What can we do about it, if anything? And we try to give a bit of a positive indication of what some of the things we can do. We have child psychiatrists that looked at this topic in the article, one from Harvard and Boston. We have a past president of the World Psychiatric Association, it's part of it, psychologists, psychiatrists, a whole international team looking at this topic. And so I would ask you to take a look at that article, and you'll get a lot of information. We put together over 700 references, 22,000 words. We looked at things that I would do if I had more time with you this morning and for your afternoon before your dinner. What is the epidemiological data? It's unfortunately very high and it's getting worse, at least in the United States. You can see what's happening in Greece, what's happening wherever the country, in Ukraine, wherever you're coming from. You'll have your own individual issues going on. What are the risk factors behind this? In the United States, there are many, of course, risk factors that we could look at. Child abuse, for example. The two big factors I would say to look at, where I am in Michigan, and probably in Florida, probably in Texas, other places, one would be cyberbullying and bullying that takes place with our children. And another is the widespread use of guns, firearms in the United States. And the two are now becoming a very deadly combination. When I was a young boy, several decades ago, if you were bullied, you had two choices. One, you could just take it, or I'm from New Jersey, grew up close to New York City. And so what we would do is just go fight as a boy. You would have to take the bully and go fight. They didn't have a gun. They just had their fists, and you would fight and see who won. And then the bully would generally leave you alone. We didn't have cyberbullying at that time. Well, now we have cyberbullying and bullying, which goes on. And then what we're seeing in the United States is the person who's being bullied is taking a gun, going into the school and attempting to kill the person bullying him. And if he or she can't kill the bully, they'll kill somebody else. And we're having this terrible epidemic of violence via guns in this country. So if you combine those two, bullying with firearms, you have a very deadly combination. The other problem we're having, and maybe in your country, maybe not, maybe you have other issues, war may be going on, other things happening. We're having the issue of drug addiction. We have a plethora of opioids in this country, and kids can easily get hold of not only guns, but opioids. And we're having a large opioid epidemic and death through heroin, fentanyl, other things. So we're having those two very deadly combinations which are occurring. Another issue is happening if you're a child and say you have attention deficit disorder and you're very impulsive and you get angry about something at home, angry about something at school, and you're very impulsive. If you have a gun in the house, you get your father, mother's gun, then you combine your impulsivity and your immediate anger with the gun. That's called suicide by death. If you can, so part of the issue would be those are some of the factors occurring. In the article, we talk about that. We talk about many other factors, of course, family dysfunction, such. Then we get into some issues of protective factors. Well, what can we do to protect our kids? I'll give you a few tips about that. It depends where you live. What are the issues going on? When you study this topic of suicide, I urge you to look at the issue of neurobiology. In the article, we talk a lot about the neurobiology of the brain that's depressed and the neurobiology of the suicidal brain. And those are two different issues. And then we get into issues of suicide assessment. And we stress a lot about when you have a teenager, a child, teenager, young adult in your office or wherever they are. In this case, if we're clinicians, they're in the office, you reach out and you assess how they're doing. And you ask about what they're doing and ask about their life. We're having a bit of a problem in the United States where doctors are now under the control. They're working for a business corporation. And businesses, of course, want to make money. And so they're having less and less time talking to the child, talking to the teenager, because the more patients you put through in that hour, the more money you make for everybody. So it's hard to get that time, but we still urge the clinician to spend time, the nurse, the physician, others, ask about this situation. How are you doing with life? If you have one question to ask, you would focus on that. And then if you have more time, you can do some things later. There are many suicide assessment plans which are available that you can look at. It depends upon who you are, what your training is, but there are simple questionnaires. There are more complex ones, but use one of them. And then a very important message. If you have the child who is depressed or anxious, or thinking of suicide for a variety of reasons, the most important thing you can do, and I don't care if you are chair of psychiatry at the Kapodistrian University in Athens, if you are chair of psychiatry at Harvard, at my place at the Western Michigan University Homer Stryker School of Medicine, if you're the nurse, if whoever you are, reach out and provide what is called supportive care. And let them know that you do care about them. You represent a whole team of people that you know that if you can't help, you'll find people who can help. And we'll reach out, because when you are in the issue of feeling sad, anxious, angry about situations in your life, and you are a young child who doesn't have the advantage of several decades of reflection about life, who doesn't know what to do, doesn't know where to turn about the bullying, doesn't know where to turn about the family issues in that there, but all the things that can occur, doesn't know where to go, you can be that beacon of light. You can be that person who can reach out and say, let's talk about this. You can get them into therapy, and we talk a lot in the article about individual therapy, family therapy, group therapy, lots of ways to help them. Once you can stop that brain from actually committing the suicide, and you can then sit down and say, okay, what is going on in your life? Because each suicide is an individual story, the combination of factors. I, as a professor of pediatrics, feel that my role is to try to get them into their adult years. Take the first 25 years of life when the brain is undergoing major changes occurring, get them through that first phase of life into their third decade of life, fourth and beyond, my case entering the eighth decade of life, where suicide is a very high issue. Get them into their adult years and then decide what life's all about and talk to your adult provider and others and therapy and such, and reflect on what is it all about and so forth. But at least get them through that time. And so in that article, we try to get some ideas, and then some ideas of prevention. There are no drugs you can give the person, psychopharmacological agents to help them. If you have depression, antidepressants may help you. That's more of an issue, I would argue, with my colleagues in psychiatry, more of an issue for adults with depression, but we can look at that literature. The problem with some of the medications you use can also increase the suicidality in that suicidal brain. If you look at the neurobiological issues that are going on, incredible science which has been developed from the time I was in medical school until now. The scientists have come up with amazing discussions of the neurobiology of that depression, the neurobiology of anxiety, the neurobiology of that suicidal brain, amazing discoveries of neurotransmitters and what we call the endogenous opioid system in the brain, the system with its connections throughout the brain that lets you feel good. You're about to have dinner at the yacht club soon. It's going to make you feel good. You're going to light up that system. You may or may not have a glass of wine or something else to increase that. But the system that makes you calm, the system that helps you deal with pain, the system that helps you live. And that system is undergoing major changes in the child, the adolescent, the young adult. And so if you can reach out to them and provide that support to get them then into therapy, if they have the money, if they have the healthcare insurance, if you have people that you can associate them with. Medication alone is usually not the answer, although you will find some individuals that have depression, anxiety, and maybe medication might help them. There is some very fascinating research going on brain stimulation, from electroencephalograms to actual brain stimulation procedures, which are just in its infancy. I would say in the next 20, 30 years, that may become a more viable option for individuals to have for therapy. But right now, it's a matter of identifying that person, and you can use a variety of assessments. Are you feeling okay about life? Are you feeling depressed, anxious? Are you thinking of hurting yourself? And you will be amazed, if you haven't done this, on how many people in a difficult world are feeling sad, anxious, are thinking of hurting themselves, are thinking of ending their life, and looking for someone to reach out to and begin to steer them in a better direction. Think of yourself in your career, your wonderful careers you all have in school, in universities, in graduate schools, people that helped you. Somewhere along the line, I have that in my life. Every so often, when I needed that help, someone to put me in the right direction, put me in the right road, go in that direction, talk to that person. Think about this, reflect on this, just at the right time, as I wasn't quite sure which the road to take. Well, the kids need that. And you can be that person. If you're a PhD, you have a master's degree, undergraduate degree, you have no degree, you may be that person to reach out and help that particular person. Now, it's not easy. In the United States, a big factor with this is violence. Maybe in your country you have the same thing. We're a very violent group of people, and I hate to sound like an old fella here being negative, but we live in a very violent world, and suicides and homicides are two major factors that are causing the death of our children. And I could bore you with, I won't do that anymore, with the statistics. Any data you look at from almost anybody, if you look at why do children die, why do teenagers die, why do young adults die, it's a combination of unintentional injuries, motor vehicle accidents, for example, and other things. But homicide and suicides are far more important than that of, say, cancer, cardiac diseases, things that would occur. And what we're finding in the last 20 years is increasing numbers, increasing epidemiology, and why children are having a hard time dealing with the pressures in life. Children, I've spent a lot of time with children. One of the big issues with a child has been abuse. One of the things I've done with my life is written about and discussed child abuse situations. And if you have a child who's undergoing severe abuse, particularly sexual abuse, and they have no one to turn to, what do? Suicide becomes often an option. Another issue we find is schizophrenia. Childhood schizophrenia can be very difficult to diagnose. You think of schizophrenia with adults, older adults. You don't always think of psychosis in the child. And that can be a very difficult diagnosis to make. So that can be an issue. I mentioned the attention deficit disorder, impulsivity. Counsel the parents. Do you have guns in the home? If you have impulsivity issues, that can be a serious actor, a serious problem. Assessment. You can find many instruments, the Columbia scale. There's a number of scales, and depending upon who you are, who trained you, where you go, the important thing is to reach out, ask the person about this, and then as you ask the person, and then you develop your system. How do you get along with your patient? Do you know them? If you don't know them, if they're just coming in for one exam, you haven't seen them before, you'll never see them again, that puts a lot of burden on you as a clinician to get along with them. But if you have a relationship with that person, I have met very few parents who get upset with me if I ask their child about depression, anxiety, suicidality. I've had a few, but very, very few who get upset. There are warning signs that we talk about in the article, changes that occur in behavior, in clothing, in sleep, and things. Sometimes you'll find a child will admit they're becoming obsessed with suicidal thoughts. The issue is, in that moment, if you can ask about how they're doing, if they will admit to you they're having some problems, if you can stop the suicide right there, get the guns out of the house, get the parents alerted if they're there, if you can then tell them, I have a team that works with me. I care about you. And I, with my team, can find out what are the issues and reach out and provide them hope. What children need is hope. They don't know. They're children. Their prefrontal cortex is immature. They're going through rapid changes. There may be lots of things going on in the family, at the school, other situations where they're at, and they may have problems finding anyone who cares. You can be that person. Now, there's lots of plans, lots of ways to do this, and in the article we give lots of situations there, but with the shortage of child psychiatrists in the world, shortages of psychologists in a lot of places, the clinician becomes a very important person to screen, ask what's going on. The other issue, I would say, United States with the drug opioid epidemic going on is to ask about access to these drugs and give them some inclination about that. We're having issues with fentanyl, very powerful opioids. Ask, talk,